Good afternoon, everyone, and welcome to our Health Integrated Thought Leadership webinar, which is part of our Executive Leadership Series program. I'm Sue Janczak, Director of Marketing at Health Integrated, and I'm joined today by Dawn Shivers, also of our marketing team, to host today's event on the overuse of emergency rooms. As healthcare problems go, this one is a bit of a sticky wicket. Not all problems that present at the emergency room are true emergencies. But sometimes, and despite the fact that some things are better treated in the primary care setting, there's just simply nowhere else to go. Of course, there are a myriad number of reasons why individuals would choose the ER first. Ease of access and lack of insurance, to name just two of them. And of course, hospitals have their own reasons for not discouraging ER use. As we all know, follow the money. But at the end of the day, what's right for the patient should be paramount. So how do we break the ER use cycle for avoidable circumstances? Today's webinar will be led by Dr. George Martin, Vice President of Medical Management and Senior Medical Director for Health Integrated, who has experienced firsthand the impact of the overuse of the ER as a practicing pediatrician, and now is the head of our medical management services. His passion for ensuring individuals get the right care in the right setting at the right time for the good of the patient and to manage costs at the same time is his guiding philosophy. Dr. Martin is a licensed pediatrician and a physician executive who started in managed care in 1977 as a physician advisor to Humana Hospital Systems. This opportunity led him to be on the Quality Improvement Committee for Humana Insurance of Tennessee and to be the regional medical director doing peer review and medical necessity reviews, while also being a licensed pediatrician with an active private practice. He became involved in pediatric quality assessment benchmarking and sat on the National Quality Advisement Committee. Later, he focused on disease management, case management, and joint ventures with PricewaterhouseCoopers as a partner and then as a director. But before we get started, just a couple of housekeeping items. We are recording today's presentation and will upload both the audio and PowerPoint to our website by tomorrow. We will also send you an email letting you know when it is available online at healthintegrated.com. And to facilitate our presentation, all of our attendees have joined us on mute. Of course, we welcome and look forward to your questions, and we will allow plenty of time to answer them at the end of this presentation. However, please feel free to submit your questions through the chat box function at any time throughout the webinar. We will collect them all and answer them following Dr. Martin's presentation. Should time run out and before we're able to answer all of your questions, we will definitely respond to each of them through an individual follow-up email. And with that, Dr. Martin, I'd like to turn it over to you to get started.
Thanks, Sue. We are going to talk about the use of emergency rooms today, and we've labeled this overuse of emergency rooms, because that's how everybody views it, with perhaps one exception, and that's our prime customer, our patient, our member, our subscriber, whatever label we want to put on them. And we'll talk about that in some detail as we go through this. I attempt to put this always from the viewpoint of the customer. Unfortunately, in healthcare, we get very confused about who our customer is. I know that many of our clients, and I presume at least some of you on the phone today, are Medicaid plans. Medicaid plans oftentimes view the governmental entity as a prime customer, and that's true. And we also know that the legislatures in many states have now decided that they're going to put burdens upon the Medicaid plans to reduce the use of emergency rooms. And we'll talk about some of those reasons here in a few minutes. But clearly the system, this system is designed to get exactly the outcome that we're getting. So we need to think about things in a little different way than simply doing more of what we have traditionally done. And I will remind all of you of the third corollary to Murphy's Law. The third corollary to Murphy's Law goes something like this. For every complex, difficult to understand problem, there is at least one simple, easy, wrong solution. This is not there are no simple answers here, and I know I'm going to frustrate some of you when I get to the end of this, because I'm not going to have specific answers for your plans, your customers, and your members, because each one of you will find yourselves in a somewhat different position than everyone else. Certainly there are some common areas, but there will be details depending upon who you're dealing with as customers to make things happen appropriately. So why do plans want people not to use emergency department services? Well, the prime driver is always cost. There is a measurable cost to the use of emergency rooms. That cost is clearly higher than the cost to use a non-emergency room function, whether that's an urgent care function, whether that's a primary care function, or in many cases a specialist function. All of that is less costly than we have chosen to construct the system with emergency departments. Well, how did that happen? If I go to see a physician and the physician sees and diagnoses me and gives me medication for an acute illness, why does it cost more in the emergency room than in an urgent care center, and why does it cost more in an urgent care center than in a primary care office? Services rendered were identical. So why is the cost difference? Why have we allowed that structure to develop so that what we pay for identical services, depending upon where they're delivered, is significantly different? And believe me, it is significantly different. The cost to go to your primary care office, might be $100 or less. The cost to go to an urgent care center might be 3 times that, and the cost to go to an emergency room will be at least 3 times the cost to go to the urgent care center. I will relate. Less than a year ago, my son was visiting, and we had been fishing. And in the evening, we were putting things away. About 10 o'clock at night, I managed to put a fish hook through my finger. Now, where am I going to go at 10 o'clock at night to get a fish hook out of my finger? Yeah, would have loved to have been able to do it myself, but it's a little hard for me to do things left-handed. I'm very strictly right-handed. Plus the fact it hurts, and I hate hurting myself any more than I absolutely have to. So at 10 o'clock at night, I'm going to go to the emergency room. And we went to the emergency room, and we got our thing done, and everything went fine, and yada, yada, yada. I didn't think it was all that good. I could have done better myself, but okay. And my son looked at me, and he said, well, what's that going to cost, Dad? And I said, I don't know what the charges are going to be, but I suspect my insurance company will end up paying about $2,000 for the visit. Well, I overestimated a little bit when I got the remittance advice, and I don't remember what the total charges were. I'm sure they were close to $8,000 or $10,000 for total charges, and the insurance company obviously had negotiated that down in their final payment to the emergency department, including the physician's cost. Well, by the way, I never saw a physician, was about $1,900. Now, this is something that I would have done in my office for a 6-year-old, in fact, have done in my office for a 6-year-old, in about 15 minutes for $100. So clearly I was in the wrong location to do this. Plus the fact it took me, and it was a very rapid emergency room visit. It only took me about 3 hours to get out of there. So, cost is a relative term here. Why we allow the cost to be substantively different for the same services, I think, is something that we probably need to deal with. Additionally, we don't do a very good job of measuring the cost avoidance. The flu epidemic this year was not as big a deal as it has been in the last couple of years. Fortunately, the CDC and those who determined that what strains of influenza go in the flu vaccine got it right this year. You know, they'll be making they're making flu vaccine now for next year. They've already decided what goes in it before we have any real clue. They take their best guess usually in December, so production can start. For 3 years before that, they didn't get it right. So there was a lot of excess influenza in the United States. There were excess deaths from influenza in the United States. And there were a lot of complications from influenza. Now, influenza didn't used to be a treatable disease. It is now a treatable disease. Between Tamiflu and Relenza, we have a couple of pretty good treatments out there that won't eliminate the disease. However, they will shorten the course, and they certainly will reduce the number of complications from the disease. Given that, and combined with the fact that to get the best effect out of the antivirals, they must be started as early as possible in the course of the disease, you know, it may well end up costing us a lot less for influenza patients to be seen at midnight or 2 o'clock in the morning in the emergency room rather than wait to go to an urgent care center sometime the next day or to get an appointment to see their PCP 3 or 4 days later when the treatment isn't going to be either as effective or effective at all. I mean, how many patients need to develop pneumonia, either a viral pneumonia or a secondary infection pneumonia, and be in the hospital for extended periods to outweigh the cost of people actually going to the emergency room? So cost is an elastic term. We're not really very good at measuring it, but there are other pieces to the cost as well. Recognize that when you get to the hospital, and we'll talk about this more in a little while, there are other things that happen. There are adjunctive testing, and your likelihood of being admitted goes pretty much sky high when you walk in the emergency room door. So why do people want to use the emergency room? Well, convenience is the word that comes to mind. You can go get seen when you want to get seen, and you may or may not have that available anyplace else in your community. However, for those of you who have been to the emergency room, and you'll note that I've talked about there being a 3-hour visit to get a fish hook out of my finger, that's a very short visit. I was left sitting in the waiting room for about 45 minutes, not only with a fish hook in my finger, which happened to be a treble hook on a lure with another treble hook flopping in the breeze, threatening to grab another finger. So I sat very, very still for that 45 minutes. But that is a clear, short time in the emergency room. That's a very short wait for a non-emergent situation. People come in the back door on the ambulance who are in the middle throes of a stroke or a heart attack, or they're trauma victims. They're clearly going to get treated first. So going to an emergency room has some convenience issues, but it generally is not the world's nicest place to be, although many of you will note that there are probably billboards in your town for various hospitals that say, come to our emergency room, wait time right now is 8 minutes. They are actively soliciting your members, your subscribers, to come to their facility for care that might be delivered elsewhere if there weren't barriers to getting it delivered elsewhere. So the long and the short of that, I think, from the patient's perspective is, when I'm sick, I want to get it taken care of. You know, I don't think we have many people showing up in the emergency room for routine maintenance of chronic disease, whether that's hypertension, diabetes, or others, although there may well be some of that. most of that is scheduled. It can wait a week. It can wait a month. It's routinely scheduled every 90 days, every 6 months, whatever that rotation is that needs to be for your chronic disease, and is not a big issue in terms of primary care. On the other hand, for those of you who have tried to make a primary care appointment, you know, try calling your primary care doctor at 4:30 in the afternoon when your kid is sick with 103 fever, and what happens? Well, what happens is the physician never knows that you called. Somebody at the front desk tells you go to the emergency room. That's a real barrier from a plan's perspective in terms of getting services for that patient or for that member of the plan, in that there clearly are issues around how you get into your primary care office. And those issues are usually not associated with the physician, believe it or not. I know a lot of plans that go out and try and teach their providers, i.e. their physicians, that it's important to see these people. And the physicians will sit there and nod their head. You'll get a bunch of them together. You'll give them dinner, and they'll sit there and nod their head about, oh, yeah, that's what we ought to do. Yeah, that's great. Okay. Problem is the physician doesn't answer the phone. And that call is never going to get to the physician. I will date myself because when I went to school, one of the things you had to read was Gulliver's Travels. And for those of you who have read Gulliver's Travels, you will remember that in one of the lands that he visited, there were flappers, and flappers are people that wave the ears of the king or the emperor or whoever you were trying to get an audience with in order to get them to listen. Well, you can't get by the clerk at the front desk to even get to the nurse, and, you know, the story is, oh, it's 4:30 in the afternoon, you can't get here for a half an hour, we close at 5, go to the emergency room. That's what you get in the real world. The other part of that is they may really not have any capacity. Primary care is under capacity in most places in the United States, predicted to be seriously under capacity over the next 10 years. So getting into a primary care office is problematic. The alternative, of course, is some level of urgent care. Urgent cares have been springing up all over the United States. It's sort of the convenience office of record. It isn't very good for continuity. They are sort of in a parallel system at this point. So you go to a convenience, urgent care center for convenience, and to try and save some money, and we'll talk about barriers here in a minute, which is what plans do. You get in, you get seen, you get put on some medicine, you get well or you don't get well. Hopefully you get well, but if you don't get well, you know, the follow-up, the continuity of care is terrible. You go back to the same urgent care center and some other doc is there, you have some level of medical record, but there really isn't any history, no longitudinal record to rely on. Perhaps someday if we ever get a computerized patient record, that will change, but frankly I rather doubt that that will change very much, because even if you have the old records available, if you're working in an emergency room or you're working in an urgent care center, the issue is finding the time to review the old records. So it's a very difficult situation to address. But in short, people go to emergency departments for convenience. They want to get seen when they want to get seen. And if you're a Medicaid plan, please look at who is accessing that convenience. You will find two groups that access that convenience. That is people with serious chronic illness who have acute exacerbations. They're going in with their chest pain. They're going in with their congestive heart failure. They're going in with a flare-up of their COPD literally at 2 o'clock in the morning, maybe 2 o'clock Saturday afternoon. They're going in when they don't have other access. Those people, you probably want them to get in and get seen. The biggest single group, though, identifiable group, tends to be children between 18 months and 3 years of age. And those are children with their first serious acute febrile illness. The kid's 2.5. The kid's got 104 fever. Mama is 16. She has no clue about how to take care of the baby. You could say, well, she's probably got grandma around somewhere, which is probably true, but if grandma had any clue, her daughter wouldn't have had a child at 14.5, okay? So there's a whole set of issues in that community with being able to access information appropriately, and the hospitals are clearly trying to attract that crowd, because that is who is going to be making decisions for family health care for the rest of those, the rest of their days. And that's a typically less mobile patient. They're going to be there if they can walk in and get seen in a pediatric fast track or some kind of parallel urgent care center, and they have just made that hospital their home. And they've gotten better service there than they are likely to get other places. Guess what? You got pretty good service. You got in. You got your kid treated. You got your concerns that your child was going to die of fever taken care of. You went home and everything was fine. Now where are you going to go for your next time? Who are you going to call? You're not going to call your primary care anymore because you got good service. So what do plans do? Well, interestingly enough, we've tried excuse me, to create barriers. The biggest barrier we create is typically financial. We put a copay barrier on going to the emergency room. 10 o'clock at night, I don't much care what the copay barrier is to getting a fish hook out of my finger. I think I had a $200 copay barrier. Okay. Would have only cost me $100 had I gone to an urgent care center. Of course, it wasn't available at 10 o'clock at night. And it would have only cost me, almost nothing. I would go and see my primary care doc the next day, who probably didn't have an appointment, and I probably am not going to try and go to sleep with 6 fish hooks floating around my hand. So, we create financial barriers. If you're a Medicaid plan, that's not really very effective. The reason people are Medicaid, there's not any money to begin with, so you can't create an effective financial barrier for someone who doesn't have any money to be making decisions on. So given that, creating barriers, while it is our historic approach to keeping people out of the emergency room, it has not proved to be all that effective. So we've tried education. One of the questions that actually came into it, we put a call for questions out actually before this, is what do you do with patients who you have educated and they still don't go where they ought to go? Well, I'm going to suggest some issues later, but clearly you have not been effective, and my best guess is, and since I can't talk to that person directly, my best guess is you didn't bother to ask a member why they go to the emergency room. You might find something out if you ask them. You might find a lot out if you ask a lot of people why they go to the emergency room. And some of those issues, in terms of creating barriers, will create reaction. We created a lot of barriers years ago when managed care sort of came around in its first iteration, and essentially said, well, we're not going to pay for that at all because it wasn't really an emergency. So we tried to do post-service utilization management on emergency room visits, and the pushback we got was essentially every state in the United States said, passed legislation said any reasonable layperson who would have gone to the emergency room for this, you got to pay for it. So that's simply our customers pushing back when we try and create barriers. And for those of you who are aficionados of quality improvement, we should know when we push, we're going to get a reaction. And that's essentially what creating barriers is. We are trying to push people in a certain direction. We'll talk about it more in a few minutes, but that in quality improvement theory, creating barriers, pushing people to change doesn't create change. And I think probably many of you have seen that it does not create effective change to create barriers. Nonetheless, our finance people and our leaders will continue to try and figure out new ways to create barriers so that people don't access services that we don't want them to access because the cost is too high. And that's where we are in terms of understanding the whole issue of healthcare in general, and that is going to continue to be an issue for us. I did. That's good. Good, Dawn. Dawn's reminding me that I needed to make sure you could see the screen again after the telephone popped up. So we're okay. We got you back here. So creating barriers is something that I'm sure we will continue to do. I'm just saying that it is not, theoretically, it's not going to be particularly effective, and I think in practice we have found that it is not practically effective either. Oh, let's talk about hospitals for a minute. Why in the world do hospitals want people to use emergency department services? And it's revenue, but it's not the revenue that you're thinking about. Emergency departments, if you look at them in isolation, tend to be money losers. Particularly, the more intensive an emergency department you have, level 1 trauma centers are virtually always money. They're money pits. They suck up millions of dollars a year in terms of cost as opposed to the revenue generated directly by the emergency department. Now, you will note that I just used directly as a word, and we'll talk about that in a minute, because the revenue for the emergency rooms has to do with the amount that they get paid for the services that they render. They are not very efficient in emergency rooms. They are, let's put it this way, they're extraordinarily inefficient. And the higher intensity emergency rooms, the expectation is that they will see about 3/4 of a patient per hour per physician. That is less than 1 patient per hour per physician. So if they're seeing 100 patients in 24 hours, they've got to have a bunch of people, a bunch of physicians there. The physicians always want physician extenders. I was in an emergency room not too long ago where they're using computer on wheels. For those of you who know what computer on wheels is called, they're called cows. And they have a typist, a scribe, if you will, pushing the cow around, following the physician. The physician goes into the room to do his history and physical and provide care for the patient, and the stenographer is typing everything into the cow. And then, of course, you'll note that I also said when I got the fish hook out of my finger, I never saw a physician. I saw a nurse practitioner, and I used to train nurse practitioners, and nurse practitioners are my friends, but they're not trained to do surgical procedures, and this one filled that bill. That's not what they're trained to do. PAs are oftentimes trained to do surgical procedures, usually as an adjunct to working with a surgeon. And I hope somebody has actually tried to train this nurse practitioner, but she was going to do it her way, and so it took my finger, I don't know, 3 months to get fully healed, as opposed to doing it the easy way. So be it as it may, there is significant revenue for the hospital from a emergency room visit, because today, the average hospital in the United States, 70% of their inpatient admissions come through the emergency room. That's where the money is. It's not in treating emergency department patients and getting paid to send them home. It's in admitting them and getting paid for the inpatient care that those members may or may not need. If you look at Medicaid populations, and I've had the opportunity over the years to recurrently look at Medicaid patients being admitted through the emergency room, the likelihood is very high that they did not need to be admitted for the condition which they presented. It is as high as a third of the members who are admitted through the emergency room for medical conditions. Now, surgical conditions are different. You got acute appendicitis, you got your leg cut off and multiple trauma. That's a different issue. But medical patients, as high as a third of them, do not need to be admitted. They need maybe an overnight stay to ensure that they don't get sicker. That's about half of them. The other half of them didn't need to stay near the hospital at all. And remember, when you admit someone to the hospital, and there's some of this in the emergency room itself, but when you admit someone to the hospital, you're putting them at risk for a lot of things, including dying. It's 15 plus years ago, maybe 18 years ago now, the Institute of Medicine report came out to Err is Human, talking about medical errors, and many, many medical errors happen in the hospital. The system is extraordinarily complex, and so there is probably close to as much likelihood that you will need to stay in the hospital after you get admitted because of something that was done to you, as you needed to stay for what you arrived with if you're a Medicaid patient. Medicare is a little less likely because Medicare patients tend to have more chronic conditions, and certainly somebody with an acute exacerbation and decompensation of their congestive heart failure or their chronic obstructive pulmonary disease, those patients are more likely to need inpatient care. But even there's a 15% likelihood that those medical patients did not need to be inpatient, and we are then subjecting them to all of the risk of being an inpatient without commensurate benefit. So remember, the world lives on, if you will, a value of a risk-reward ratio, and if it's all risk for no reward, that ain't will come out well. It's not going to come out well for healthcare. It's not going to come out well for the patient. It sure isn't going to come out well for the plan, because now instead of a 1 or 2 day stay for something you didn't need to really be there for, but you got well enough to go home, now something bad happened, and now you're there for 2 weeks because of a complication that shouldn't have happened. Suddenly, the cost to the plan goes sky high. The revenue to the hospital goes up, and I will tell you, the hospital does care about it. They certainly don't want a record of complications going into place, but that's mainly on the medical side of the house. Finance isn't necessarily all that concerned with it, as long as the revenue stays up. And my sister did say, no mission, no margin, no mission, which is true. Flip side is how are we generating that money appropriately, ethically, and with the best interest of our patients in mind. All right, so I've been real long-winded about talking about the issues about why people go to the emergency room, why plans don't want them to go to the emergency room, why hospitals do want them to come to the emergency room, and there is a whole gamish within our system, and it differs across parts of the country. It differs quite a lot. I think it differs more than one would expect. If you go to LA County, it's clearly different than New York. If you go to Washington State, it's clearly different than Washington, D.C. The systems are not the same. Even though the care, we've set national standards of care beginning probably 30 years ago now, the way the systems grew up, the way that they're operated, and the financial incentives that have been built by the states, in particular around Medicaid, are seriously different. So what should you do? What should you as a plan do to reduce the use of emergency department services? Well, go back and remember who's making the choice. The patient, the member, the patient's mother. Somebody's making a choice to go to the emergency room. Remember, we put up barriers trying to keep them from going in that direction. So we've got walls, but people push against walls. People find ways around barriers. So in theory and in practice, the way to get people to change behavior is make it easier for them to go someplace else. Make it better, obviously better, and that's not better from the plan's perspective. That's not better from the physician's perspective. That's not better from the state legislature's perspective. That's better from the member's perspective. How is it better to go to a primary care office than it is to go to an emergency department? Well, if you go to the emergency department and you're whisked in because you've got a sick child into their pediatric fast track, and you get seen by a nurse practitioner and you get comforted, and your child actually gets some Tylenol and their temperature comes down and everything's hunky-dory, and you get treated like royalty while you're there in a nice, clean, bright environment. You walk in, they take care of you, you know, you're feeling pretty good about it. You're a Medicaid member, you probably didn't pay anything for it, at least nothing out of pocket. The money comes from somewhere, but it's not coming out of your pocket. So the barriers, the financial barriers that we've put up don't work. So let's not worry about that. Let's figure out what the barriers are to people going somewhere else. Well, for crying out loud, if you're a Medicaid member and your day starts at noon and isn't over till midnight, well, you know, you got things you want to do at 10 o'clock at night, and if one of those things is you or your child happen to get sick at 10 o'clock at night, you're going to access services then. You're wide awake. That's your lifestyle. Well, we haven't changed the rest of the system to match that. The only place you really usually have to go at 10 o'clock at night is the emergency room. So what are you going to do? You just notice that your child has got 104 fever. It's 10 o'clock at night. Who are you going to call? You know, there's very little way to get information to that member or that member's primary caregiver, and there's no other place for them to go. Certainly no easier place for them to go. No prettier place for them to go. Have you been to your primary care physician's office lately? They got a waiting room. They got some ratty old chairs sitting out there that, you know, that one time they were upholstered. Now they're, you know, the upholstery is pulled out or they're cracked and broken. You get sat down in the waiting room. The receptionist closes the window as soon as you leave the sign-in sheet after she's made sure she's got your insurance information, and you have no clue what's going on. You can't see what's going on. There's likely no Coke machine down the hall if you need something to eat or drink while you're waiting, and so it's not very user-friendly. So how are we going to partner with those providers who we wish to see, to have our members go see? And remember, we're paying $1,900 to get somebody's fish hook out in the emergency department. We're probably paying about that much to get their ear infection treated that they clearly didn't need to be there for. From a medical perspective, how are we going to get things changed? Well, let's remove some barriers, okay? First thing is identify them. A number of ways to identify barriers. Probably the easiest way to identify barriers is to actually ask your customer. Now, you have customers that may or may not be easy to catch. You have customers who may or may not say what you want them to say when you ask them what the barriers are. Collect the information, understand in your market, with your membership, which may well be different than membership of your fellow plan down the street. Your membership may be different for whatever reason. You may have an ethnic group that has decided to join you. Don't know why, but some ethnic groups, they talk within the community and they say, well, we like Plan A, so everybody joins Plan A. So now you've got this, 15% of your population that speaks Croatian as their primary language or some other language. Who knows? You're going to have to communicate with them to identify what they perceive as barriers to going in the direction you want them to go. Whatever that direction is, do you want them to go? Do you decide you want them to go to urgent care centers? You may be able to contract much more effectively with an urgent care center to provide after-hours services than your typical primary care physician. Primary care physicians are, typically their office hours start at 8:30, 9 o'clock in the morning, and they want to be going home by 5 or 5:30 in the afternoon. Can't say as I blame them. I would have liked to have done that too. But to say that you want them to start early, you want the office open at 7 a.m., and you don't want them to close until 9 p.m., how are they going to staff that? They're not equipped to do that. They're not equipped to do that for a number of reasons. You may want to contract with your primary care physicians, or you may have a primary care group who's the focus. There's a real easy way to do that. You want to shift to save money, shift the money, move some of the money. And I know none of you want to do that either. You're going to get a lot of pushback from your finance department. When you go to the finance department, you tell finance department, we want to pay our PCPs for E&M codes. We want to pay them twice what we're paying them. Well, that's going to go over well. Okay, I can just see the CFO look at you and roll her eyes at like, you want to do what? And we want to remove the barrier to getting our members seen, get strange hours for extended hours, or just to increase the capacity to get our members into PCPs. Or maybe it's easier to address the issue with urgent care centers. Urgent care centers tend to have somewhat extended hours. Typically they're open 10, 12 hours a day as opposed to 8 or 9 hours a day. They typically open a little later in the mornings, but some of them are open early, and many of them stay open till 9 o'clock, some to 10 o'clock at night. After 10 you may be out of luck, but the volume does tend to fall off after 10. And you should identify with data what the population you want to move. It ain't going to help you at all to ask a 55-year-old disabled person about what the barriers are to them getting care when your issue is with 15-month-old kids. It's just not going to help you at all. So you need to identify what population you want to move, and remember that the barriers to them going at 18 months may be a lot different than a 55-year-old who's got end-stage renal disease. I mean, they're totally different issues. You probably got both in the population somewhere, but identify subsets of the population that are drivers, identify what the barriers are to them accessing care in a way that you want for them to access the care, and then figure out what you can do to remove those barriers. I haven't talked at all about the traditional things that we do in terms of disease management, case management, and other issues. And I'm not going to. I'm not suggesting that those aren't good things. They are good things, but they aren't what you're trying to do here, or maybe they are. That's going to depend upon what your data shows. If your data shows that your issue is congestive heart failure patients showing up in the evenings and getting admitted, you know, every 3 weeks to the hospital, and you don't have you apparently don't have an effective disease management program around congestive heart failure, I would suggest that that is unlikely to be an identifiable issue. But as I said, from market to market and plan to plan, it's going to be different. So I'm not going to make blanket statements and say, here is the one thing that you need to do, with one exception, and that is, it is very clear for Medicaid plans that a huge driver of emergency room use is otherwise normal preschool age kids. And that's an issue that we routinely see when we do looks for our clients. It may not be specific in your market, and I'm not going to make a universal statement, but I have yet to see it not be an issue. Not going to be your only issue by any means, but certainly will be an issue. So with that, I think we're coming up into the last 10 minutes of the hour, and we'll take questions.
Thank you so much, Dr. Martin. There's just so many facets to the problem and different ways to approach resolving it. It sounds like first and foremost, whether you're a Medicaid plan, a Medicare Advantage plan, a commercial plan, it's doing the research.
You need to understand what your population is and what the drivers are within your population so that you can address it. For those of you who don't remember, to go back to quality improvement, there was a nice Italian guy by the name of Vilfredo Pareto. Vilfredo Pareto was a tax collector, and Vilfredo Pareto demonstrated that in Italy in, I think, the 1800s, 80% of the taxes were paid by 20% of the population. The old Pareto diagram, 80-20 rule, falls out of that. Don't work on the 20. Work on the 80% that is probably represented by 20% of the population so that you can focus your efforts. You can't do that without some kind of initial data to say we have a problem definition that's attackable by specific techniques, and that we can measure that we've had an effect when we've done that. So identify the problem, design a solution, implement the solution, measure your results. Again, to go back to classic quality improvement, that's plan, do, check, act, PDCA.
Very good. Dawn, I see we have another question.
Thank you. Dr. Martin, can you talk a little bit about how to handle those who use the ER for pain meds, chronic housing needs, and of course those who are aware of their PCP but still continue to go to the ER?
Well, let's take the first one first. Being aware of your PCP is not equivalent to actually being able to see your PCP. And I think, this, from the nature of the question, this sounds like it is probably a Medicaid plan. And I have seen many Medicaid plans who have assigned and made the subscriber, the member, quite aware of their PCP. And then I've also seen the same PCP offices that are getting a capitation fee for providing care for those members put barriers up to the members actually coming in. So you need to understand whether or not your PCP, who you've contracted with, is actually fulfilling their part of the bargain. Chronic pain management, I think, is a totally separate issue. Chronic pain management usually has nothing to do with pain. Chronic pain management has to do with drug dependence. And when you run out of your Dilaudid at 2 o'clock in the morning and you start having withdrawal, I will guarantee you are not going to make an appointment with your PCP. Now, there's 2 ways to run out of your Dilaudid. 1, you can have taken it all yourself, or 2, you could have sold it. So I think there's a whole set of issues around chronic management of people who have pain syndromes who are on narcotics in particular. Those issues need to be dealt with. Those probably, if it's possible, those members need to be they need to be directed. They need to be restricted. That's a little different population than I was talking about in general. They have a very specific need that the plan needs to help them with. There's obviously also a set of people who actually have pain that needs to be treated, and I told you it's different from market to market. In Florida, I mean, I live in Florida, okay? About a year ago, the state began shutting down the pill mills. We had a lot of urgent care centers in Florida that were doing nothing but handing out prescriptions for narcotics. And we're making pretty good money, but clearly they weren't doing what they should be doing. On the other hand, I've seen markets where the pain management docs do an extraordinary job of coordinating the care, managing the care, and really feel bad when they can't get their patients off of pain meds. I've had some lovely discussions in other markets where that's true. I'm sure there probably are some in Florida where that's true. Unfortunately, in Florida, they were pretty much subsumed by the pill mills. Hopefully, we've got that under some semblance of control at this point. But I think, as I said, every market is a little bit different. Your providers may be different than the general run-of-the-mill provider, and you're going to have to evaluate that on an individual basis. But, Dawn, was there a third part to that question?
It was the homelessness component.
Oh, the
Are they
homelessness
using it for residents?
Okay.
And that actually brings into mind some of the behavioral health issues as well that are associated with that population.
Certainly the homeless population, and again, for the Medicaid plans, this is going to be state specific. I deal routinely in medical necessity issues. Because you show up at an emergency department as a chronic alcohol abuser and don't have a home to go to, as a commercial plan is not my problem. As a Medicaid plan, it may be your problem. That your state may have some mandates for you to provide some level of services for that population. Again, it's going to be state dependent. California has got some issues that I'm aware of because we do a lot of business in California. State of Texas, on the other hand, would basically say, you know, you're out of luck. Okay, you came in. We're not going to give you 3 hots and a cot at $1,500 a day for staying in this hotel that we call a hospital. You just, you know, state of Texas is going to say treat them and street them. And in California, they're going to say, oh my goodness, they've got no place to go besides under the bridge. So we'll put them upstairs and they'll be here for the next 37 days at $1,500 a day, which happens. It happens all the time. So you're going to have to deal with that depending upon your state mandates. If you're a Medicaid plan, to put my utilization management hat on, the issue is, again, number one, what's the benefit of putting you into the hospital, because that's what we're talking about for a homeless patient, versus not putting you into the hospital. And I will tell you, you are going to be a lot safer in terms of complications at the Union Mission than you are on 3 West. 3 West, you're not going to get a hospital-acquired infection at the Union Mission. It's not going to happen. Only place you can get a hospital-acquired infection is in the hospital. And you can get it whether or not you are seriously ill with open wounds and got run over by a tractor, or because they put you up there because you needed someplace to stay the night. You're still at risk for the complications of being in a hospital. On the behavioral side, again, very, very state-driven, and the relationship between the acute care hospitals and the behavioral health providers, how do I put this in a technical way? It tends to be pretty crappy, okay? So what happens is you get a behavioral patient into the emergency department. The emergency department doctor does not have a clue what to do with that patient. So they ask for a behavioral health consult, and 2 days later a social worker shows up. That is very common across the United States, and it's difficult at best. So what happens is, of course, nobody wants that patient in the emergency department, least of all, certainly not the emergency department personnel, and so they want to admit that patient pending the behavioral health consult. That's an issue that the plans probably need to take up with the behavioral health providers. If there's a behavioral health issue, the behavioral health providers need to get out of bed at 2 o'clock in the morning and go deal with it. I'm sorry. I'm just, on the medical side, we've dealt with 2 o'clock in the morning issues forever. The behavioral health providers need to deal with them as well.
Great, thank you. We have time for just one question. We've got about a minute, and I want to go back to the educational piece of that. We're asking people to be better informed decision makers across the board. And your son had a very insightful question. Dad, what will it cost when you went to have your lower removed? We've tried that. It hasn't necessarily worked well, but certainly there must be some other things that we can try. Is it a method of educating? Is it using nurse lines? Are there other things that are showing up through like TCMH that might be showing proven successful, even anecdotally?
For those of you who are on the phone who used to read my blog, I used to write a weekly blog, did for about 1.5 years about the patient-centered medical home. And if you read it, you will note that I was fairly skeptical that it was going to have a significant impact. And I think, again, we have designed things from the perspective of the system, the providers, the states, the legislatures, the plans. We put things together that we think will work for us that seem to be good things. We're not very good at asking our customers. Go ask your customers, find out what they need, and build whatever it is they need. Measure, monitor, and make sure you're getting the results you want. Because until we do that, we're not going to get the results we want. And for those of you who have seen the results about the patient-centered medical homes, they are not getting anywhere close. With a few notable exceptions, those exceptions, I would say, have actually addressed the needs of their customers, their patients. But if they're designed by the plan and the providers, they're not getting the results we want.
Very good. Well, thank you so much. That brings us to our time. So thank you, everyone on the phone, for joining us today. And please join us next month when Barb Leonard, who's the Senior Director of Project Excellence for Extenda Consulting Services, is going to discuss opportunities for quality improvement and compliance in the worlds of HEDIS and STAR. And that will take place on Wednesday, June 26th. So please watch your emails on our website for registration information there. And with that, this concludes today's webinar. Thank you.